this point, I wanted to introduce the commentators. So, ladies first, Dr. Rombola is our Chief Director here in the Adult Intensive Care Unit. Elias Lazaros in the middle is our Chief Pediatric Perfusionist with excellent experience from UK and here in Greece and a lot of experience in ECMO. And Dr. Dimos Avramidis is my cath lab colleague, Senior Electrophysiologist in Pediatrics and Adults. And as we know, ECMO can be used sometimes and it may be needed for children, babies with intractable arrhythmias. It has happened to us. So we are opening the discussion. Any comments that we may have from the floor? Dr. Rombola, please.
Good morning. First of all, to congratulate the organizing committee for this symposium, which give us the opportunity to be here and discuss very interesting topics. Congratulations to all speakers for their high-quality presentations. I think that the main point with ECMO is that it's to organize a national program on a national or regional basis, an ECMO program, and that's necessary to have the results we all want. So we must have an ECMO center with staff well qualified, and it must be a dedicated and high volume center. We need a network with hospitals around the ECMO center with mobile ECMO teams, and we need protocols standardized for initiating or terminating ECMO support. In that case, the ECMO can save lives, because we have to know that ECMO is a high cost, high risk, and complex modality. And if not have an organizing national program, the results won't be the results we want.
Good morning, Mrs. Tzifa, Mr. Mitropoulos, and Professor Anderson. Thank you for the invitation. It's an honor for me. As a perfusionist, I have to say that ECMO is a challenge, and also ECMO saves lives. I agree with Mrs. Rombola that we have to try to organize a national program, at least with 2 ECMO centers or 3, one in Athens, one in Thessaloniki, and maybe one in Crete. It depends on the money the government have to spend to organize this, but it's necessary. And also, I would like to talk about our unit in ΜΗΤΕΡΑ. We have about 30% success in AV ECMO, and we have a limited experience about the VV ECMO, which is 100% of success. I think we can improve the results. We believe that the ECMO saves lives, and with the opportunity of the, I would like to ask Mrs. Grigorakou if we have experienced the last about 18 months with the pandemic and the patients with COVID-19. Okay, thank you again for the invitation.
Hello. Well, we don't have a lot of data about children. As we know, when children get the COVID-19 disease, they have mild symptoms. It's only a minority of them having myocarditis or hypoxemia in RDS or in multi-system inflammatory syndrome. Most of them have targeted therapy in ICUs and go home. Only a minority of them are getting VV ECMO, but there is no deviation according to the ELSO guidelines. We have more data for adult patients above 16 years old. On October 2020, ELSO organization reported a study from January to May 2020. More than 1,000 patients were on VV ECMO due to COVID-19 disease. In ECMO, total ECMO. Of them, more than 90% were in VV ECMO, less than 4% were in VA ECMO. And the mortality was, for 19 days after initiating ECMO, was about 37.4%. This is not bad compared to the pre-pandemic season, which was 40%. So ELSO suggests VV ECMO for COVID-19 disease, and there is no deviation from the standard algorithms for cannulations, anticoagulant protocols, or lung strategies, protective strategies. It's the same. For VA ECMO, we don't have enough data.
Thank you. Thank you.
Thank you, that is great. And Dr. Avramidis, please.
Yes, I'd like to congratulate all the speakers for the detailed presentations. I would like also to thank the organizing committee for asking me to put a comment on this session of ECHO, even if I'm not a specialist and I'm a rhythmologist. As a former president on the working group on CPR and resuscitation in ICU from Hellenic Cardiological Society, I would like to say that there are recently published guidelines from a few days ago from the Resuscitation Council, European Resuscitation Council, the 2021 guidelines on resuscitation, where they highlighted the eCPR. Spirit Logos told us about the eCPR. It's an acronym for the ECMO CPR. The ECMO CPR plays a crucial role and it's have better outcomes compared to the conventional CPR. The use of ECMO increases the survival rate and good neurological outcome after months. And I would also want to say about meta-analysis and proportional matching cohorts that say if you use eCPR instead of conventional CPR for refractory VF and VT patients, the number needed to treat is 1 to 7. 1 to 7 means you have to cure 7 patients and have one good outcome. That means that the ECMO is not a fascinating modality, something luxurious. I think it's a necessity for every center that has to deal with this kind of patients.
That's fantastic data. Thank you, Dimo. And Dr. Pitsis, would you like to add a final note before we close the session? We are running just a little bit behind.
Yes, thank you, Aphrodite. Just a comment by Dr. Saris that we should comment on the need for distal leg perfusion on VA ECMO. It is very, very important, as we all know. Otherwise, we're going to have very serious thromboembolic complications, and we may compromise the whole issue of supporting the patient with dismal effects. I would like to thank again the organizing committee, congratulate Aphrodite and Fotis, and I think we can close this session now. Thank you very much.
Thanks to everyone. That's a wonderful session. Thank you.
Thank you.